Good morning, ladies and gentlemen, and welcome to the latest Public Sector Catering webinar. Today we're dealing with the next steps for the hospital food review with our good friend Phil Shelley, who chaired the review and is now working on it full time. We'll then go on to talk about technology in the hospital kitchen with our sponsors, Synbiotix. So the agenda for today will be, we'll open with some introductions, then we'll have an interview and a Q&A with Phil before going on to talk to Abigail Cork, Programme Manager at Health Facilities in NHS Scotland, Gareth Hughes, Divisional Director of Estates and Facilities for NHS Wales, Mark Edell, Project Director at Synbiotix Solutions. The event will be chaired by David Fode, Editor of Public Sector Catering. We've still got people joining us. Today, if you could use the chat function to post any comments and to introduce yourself to people, please use the Q&A for questions because it's hard to pick out questions from the chat. So it's just much easier if we use the Q&A function for questions, please. Okay, I think we've still got a few coming in, but I think we're probably in a good place to start now. So I will pass over to David Fode, Editor of Public Sector Catering.
Right. Well, good morning. As Andrew said, I'm David Fode, Editor of Public Sector Catering magazine, and thank you for joining us for our latest webinar. Today, we're going to be exploring the next steps for the hospital food review, an event which is being sponsored today by Synbiotix. We shall look at what's happened since the review was published late last year, at how trusts are engaging with it, at what the next government spending review might deliver in terms of funding and support. And we'll be taking a special look at the role of technology to help hospitals and caterers in particular to rise to the challenges the review presents to them. We'll be doing this in the company of Phil Shelley, Chair of the Hospital Food Review, and whose new role with NHS Estates and Facilities places him in a position to actively follow up the recommendations made in that review. Good morning, Phil.
Morning, David. Good to see you.
Lovely to see you. I'll be talking to Phil about these issues in just a moment, but as I said, we're also finding out about how technology can play a part in all this. And to help us, we'll be hearing from two people who have been actively involved in implementing technological changes where they work. We've got Abigail Cork, Programme Manager at Health Facilities, NHS Scotland. Good morning, Abigail.
Good morning. Thanks for having me.
Okay, lovely to have you here. And we'll also be hearing from Gareth Hughes, Divisional Director of Estates and Facilities, NHS Wales. Good morning, Gareth. And we're also joined today by Mark Edell, Project Director, Synbiotix Solutions, to offer his insight. Hello, Mark.
Hi, everybody.
Right, well, here's how we plan to run the webinar today. I'll talk to Phil about the review, after which we'll take a few questions from you. Then we'll hear from Abigail and then Gareth before Mark joins Phil to take some questions on technology at the end. Other than the panelists and me, everyone will be muted. If you want to get in touch during the webinar, you can put a question to the panelists using the Q&A function. Please include your name and your company and keep this to questions rather than comments or statements. And remember, you can put a question at any time. The chat will also be running, and we encourage you to engage with the issues and each other by sharing comments on that. Just remember to choose the option to all panelists and attendees. We won't, unfortunately, be able to answer any questions that you post in the chat. Right, that's the preliminaries over and done with, so let's get on with it. Phil, I think first up, it would be useful for people to know about your new role. Could you tell us about that?
Yeah, of course, and welcome everybody. Great to have this opportunity, and it's important that we regularly try to keep everybody as up to date as we can. And when you're living and breathing it, it's easy to assume that everybody understand where we're going and what we're trying to do. as you rightly said, we're leaving a trust, and more so colleagues, after over 28 years, is certainly a challenge, and it wasn't easy. The truth is there was no plan for me to leave the trust, but the review opens our eyes to opportunity. It has that advantage of driving change, and we all know that through the review there has been a big incentive to work with colleagues, trusts, suppliers, our contract colleagues across the country, and the role was offered to say, well, come and join the team, drive the recommendations. I'm working very closely with Emma Brooks, who chairs the food standards. So I've supported her through that for a number of years. And I think together we're a good team. We push each other, we support each other. We're both committed to a hospital food improvement program, and it's measurable, it's full of pride. It needs to be, of course, cost effective, driving quality for patients, staff and visitors. It's an exciting time. We've certainly got the minimum of a 3-year plan right now, but I think we all generally accept that improving the services that we work in is a continual process.
Okay. Could you perhaps tell us a little bit more about how you see your new role fitting in with the hospital food review that you chaired?
Yeah, of course. I mean, the 8th recommendation was about going forward, and when I met with ministers, they were very honest with me and said, we want this review to make a significant difference. It needs to be a real marker in the sand. How can we ensure that it gets driven at pace? And for me, there were 2 parts. There needs to be strong leadership, and there also needs to be an involvement from a team that takes that review forward. I've said before, this is not the Phil Shelley review, this is the NHS review. It's driven by us, the people that work in it, and therefore there needs to be an involvement. So I'm in the middle of a really exciting few weeks where we're interviewing applicants for the expert group. It's incredibly exciting. If you ever felt that we don't do things particularly well, if you could sit on these conversations, you'd be totally uplifted. We have got some fantastic colleagues around the country that are willing to put their hand up to say, I want to be part of that change. I want to be part of driving the area that I work in to make a significant difference. So we're right at the cusp of launching several things. Obviously, the expert group will probably be ready in around 3 or 4 weeks. We've got the exemplary trust that we now have 14. We're looking to extend that to 30 in the next 6 weeks or so. So there's lots of dynamics around how that will work, and how we can ask people in the background to be working on things to ensure that when they come around the table, that there's progress being made.
Okay, if I can just sort of pick up on this, the expert group you've mentioned, how many are going to be in the group, and what sort of people are you looking for?
Well, we're certainly looking for a couple of catering managers, a couple of chefs. We're looking at dietetics. So at the moment, there's certainly a place for one, and we're looking to possibly even extend that. We've got a couple of nurses and a couple of clinicians. So that in effect, there are 9 or 10 spaces for those professionals, with Emma and I leading that team. And then we're looking to setting up around a dozen subgroups which replicate the conversations that we've had in the past around the FM suppliers, our food and our non-food teams, our organizations, our associations, and also, a team of critical colleagues. We've got some teams of consultants that have done some fantastic stuff around the country. And we also, we want people to tell us where they think we should be going as well. So it's not just about us, pushing the way forward, but it's also about listening and understanding the emotions and the ambitions that people have got.
Okay, can you give us some idea, Phil, of how you see the expert group working?
Yeah, as I said, there will be minimal meetings because we don't think that we want to drive it from that way. What we want to do is set tasks, and those expert group will link automatically with their closer groups. So for example, the dietetic teams will work not just with the BDA, but with the speech and language. They also work with those FM suppliers that are particularly strong around some of the nutritional elements. You know, you've got obviously the dysphagia and that. So we're trying to bracket so people aren't in an area where they feel that it is not their speciality. So we want to try and use that expertise. We also committed ourselves during the site visits of the review that we would come back out again. And, you know, we're all hoping and praying that through the COVID challenges, that the gates are slowly starting to open. And we want to get back out to sites, to speak to people, to actually feel the energy, see the pressures, experience the challenges that are there. So go back to the sites we've visited through the review, but also go back to new sites so we can actually understand you know, where there's progress being made and where there are the biggest challenges.
Okay, and what sort of mechanism do you sort of envisage for taking the learning that the expert group will get from all of this work that they're going to be doing and making it available more widely for people who work in trusts across the country?
Yeah, that's a great question. And I think the first thing we need to tell ourselves is that it's important that we cannot solve everything straight away. You know, there is a 3-year plan. Everybody wants their area to be looked at first and try to take things forward. You know, we've got a passion to succeed, and that's as strong as ever. Let's make that clear. We have a detailed work plan, and there are some key areas that we're looking at. I mean, one of the things I think is really important to pick up, David, is that, of course, the food standards, the food review, and our staff health and well-being, that's a massive focus for us right now as we're concentrating on it. But I think we've also got to bear in mind, we've got the sustainability and the obesity agenda. We've got the National Food Strategy Part 2 that's coming out likely in July, which of course will also likely to incorporate the government buying standards. And then overarching that, and very much as an underpinning, we've got the net carbon zero, and that is very much driving our first part of the review. We need to be aware of supporting the economic recovery. We've got our long-term plan, the way we're going to integrate our health and social care together. And it's also understanding that how do we involve everybody in that move forward, but also understand there is a really, really big picture. We all focus on our own thing, but there is a bigger picture. So our net carbon zero will be a big focus where we will automatically, and great that Synbiotix are sponsoring today, because we feel that the IT and digital is absolutely crucial. We know that food waste is an enormous area, not just around the way we manage it, but also the way we purchase food and therefore the way we dispose of it. And our refurbishments linked into our staff health and well-being. So 24/7 catering. You know, we want to move away from vending and think of it as a 24/7 catering solution. We're better than vending. We really are. We need to understand that our staff and our visitors need food and drink around the clock that is appropriate for this age.
Yeah, it's interesting the way you've described it there, with all of these other things happening as a sort of a backdrop to what you're trying to do. It's quite a sort of dynamic environment. Are you you're optimistic though that progress can be made?
Absolutely.
Yeah.
I would be in the job if I wasn't optimistic. We all know as caterers that you know, when we did the site visits, when we've had our conversations, there were two main things that came out, and that it was the pride and the loyalty. First of all, no matter what their situation, our caterers were so proud of what they're trying to do. But there's also that inner confidence and inner positivity around trying to seek the solution that they feel is right for them. So I need to mirror that attitude of our caterers around the country. And that's not just in the NHS, that is across the public sector. All of our chairs are incredibly proud of what we've done. And COVID, as we found out, COVID has brought to the surface what estates and facilities mean to our public sector. And when I left the trust recently, I was given a book of poems. They obviously don't realize I don't read very much, but they gave me a book of poems and I read it through, and there was one poem where it said, "I'm not just a cleaner." And it's, that's really what we're about. We're not just a caterer, we're not just a cleaner, we're not just a porter. We've got a role to play. And COVID has brought that to the surface, and people know how important we are.
Okay. You mentioned exemplar trusts. You've got, I think 14, you said, and you're hoping to take that up to 30. What are sort of the qualifications in your mind that sort of make an exemplar trust? What are you looking for?
Important to recognize that these trusts don't get everything right, okay? But what they have done is they have made a significant improvement in an area, because so when you look at a trust, it may be that it is patient catering, it may be around the 24/7 solution. It could actually be in their relationships, in the way that they link with their teams. We've got a couple that are really strong in retail catering, and we mustn't lose sight that we need to create a much stronger business and commercial model within our NHS. And there's a few people that we're linking with right now that are starting to build a much stronger NHS retail. And I think there's a lot to learn from that. When you think of our teams working in difficult conditions, they want to be able to, when they have a break, go to an area where you've got great food. So I think overall, the exemplar trusts will mirror leadership. That's what they're brave, they're courageous, they're not frightened to make decisions, they're innovative, and they will drive decision making. What they will also have is they've been given a ticket to do that. So they have a whole hospital approach, so they have the support of their board, their chief exec and their chief nurse. And of course, it is easier to make decisions when you've got that support. We appreciate that. And we hope to visit sites that don't get that support. So we can speak to the board and actually say, well, these are the differences you could make if you support your catering teams and move forward.
Okay. I want to sort of take you back to the launch of the review last year. I think a lot of people were hoping for the government to sort of get behind it in a sort of a more public way in terms of endorsement than they did. And I think we all understand that obviously COVID played a part in that. Has that, do you think, diminished the impact of the review? And if it has, what can be done to put the focus back on it?
Yeah, I suppose I would see it slightly differently, David. And I've got to say, with thanks to the people on the seminar today, and with public sector catering, I don't feel it's been diminished at all, because I think all of you have promoted the change that is needed and is required so brilliantly. You've given us a platform to talk about what we're trying to do. And likewise, across the country, we have had fantastic support, very few voices of either condemnation or why is this happening again. They are very much with us. They understand that change is needed. They also understand, around our mandatory areas, so our food standards and our government buy-in standards, all of those things, how they need to be played out and how we need to move forward. Of course, COVID did take food off the headlines for a while, but it gives us a chance now to freshly launch where we're going. We're looking towards the next spending review and how any capital in that can support some of the things that we're asking for it to do. But I must say, I am still getting full support from the government. There is a lot of communication that's going on. I have to keep ministers up to date with progress. So it is important for me that if I'm keeping them up to date, then they also need to support our progress. So there's very much a two-way conversation going on. Prue is very much still involved and regularly contacts us to find out what she can do to help. And there are several things that she's doing to help us launch some programs in the future.
Okay, you mentioned the spending review. Can you give us sort of an inkling as to sort of what you would like to see in it and any sort of possible timetable for announcements?
At the moment, the spending review is due around October. There's always a chance that that will move because we know we're now in a world where things can change very quickly. And all I can do is prepare the appropriate documents with Emma and the team and put them forward. And as I said, they will very much be around the net carbon zero agenda. Okay, so we will look at the way that we manage our waste and how can we help trusts to have systems that actually manage our waste disposal. How can we help in our catering provisions and how can we support on any refurbishment and IT? So we will ask for capital to support those programs. So that's all we can do is put that on the table. It feels like, particularly with the net carbon zero agenda, that there is a real emphasis to support that program. So yeah, certainly as soon as I hear, then I'll let you know.
Okay, thank you. We've got getting some questions coming in through from our participants now. We've got one here from Stella Gardner, who says, you're talking about better retail in smaller sites, but it is not economic to have vending or cafe where it is not economic to have vending or cafe. So how do you see the 24/7 staff food for these sites?
Yeah, I think it's a really good question, and it's the angle of the question. And I can speak very much of experience where we had our own in-house restaurant in the last trust I was in, and we found it incredibly difficult to make it work as a business model. And the easiest thing for the trust to do was to wash their hands of it and give it to a contracted supplier to come in, and one looked like take the burden. And yet they've managed to make it work. So it's really important to understand that we need the right business model, but we also need to understand that sometimes things cost. But what is the payment back of that cost? And we're doing some work around sickness absence and staff health and well-being to support that agenda. And there's no doubt that if we have better facilities where we work, then that is a massive payback. Even if we reduce sickness by 1% in each trust, it's enormous. So sometimes it's not just about the pound, shilling and pence that come through a machine. It's more about the wider commitment and the support of our staff.
Okay, thank you. I'll just put another couple of these questions to you as well, Phil, if that's okay. Matthew White says that obviously the hospital food review is a fantastic opportunity within the healthcare sector. He wonders if there'll be an opportunity to work with other areas of the public sector to learn and benefit and to collaborate on procurement, learning and development to stop duplication of effort. I mean, do you see that is very much part of your role as well?
Yes, I do. And certainly the first signs already are there linking health into schools and into social care. So already that's three industries together. we've actually started to link with TUCO as well around some procurement areas. And there is no doubt that if we are far stronger together. We've always preached that message, haven't we, in the public sector, that if we want a message to get over, if we can send that message from all of us, then we have a much better chance to get through. The conversations I'm having with government is that as much as we can push together and actually work together on principles, because we are all in different sectors, but the principles are very much the same. We all want quality over cost. We want to produce food that is fantastic. We want our staff to be working in great areas. But there are the sections that we're looking at. I think there is lots of work that can be done. And great that we have Gareth and Abby here today, because we've learned a lot from Health Facilities Scotland, and we're looking also to link into Wales to understand that even though we're separate entities, there's a lot that we can do together.
Okay, I've got a question here from, I believe it's Andy Wright, who's saying that he would like to see investment in frontline catering staff in regard to training that builds on what is often just a focus on food safety. He goes on to say that catering staff play a huge role in the nutritional care of patients, and are expected to have a wide variety of skills. And he doesn't feel that's necessarily reflected in pay bandings, for example.
Pay bandings is always an emotive topic, and the only message that we've had around pay is certainly that chefs need to be at a minimum of a 3, and generally across the country now that's happening. So we've done a recce across the country, and it's looking better. What I would say on training, you're absolutely right. We're doing some work right now with a couple of industries to strengthen our chef and our catering manager program, and how that can start to influence them. Because if their qualifications are stronger and they have a greater experience, much more chance within their own trust and in their own area to be able to push their banding up a notch. And that is, generally is how the NHS works. So, we're very aware that how can we attract chefs into the NHS? How can we give them the confidence once they're in around the nutritional element, as well as the food service and the food safety? And then how can we help them to grow as managers? I mean, we're due to launch the Chef of the Year competition early in May. And what we've also realized is once we have those regional competitions complete in July and August, there's going to be a couple of days set aside for mentoring for those winners, because we understand that as part of their growth, they need to spend time with each other as fellow chefs and caterers and learn around some of the areas of expertise that will help them grow as individuals and professionals.
Right, thank you. Just going back to the exemplar trusts that you talked about a little bit earlier, Lorna Bowes asks about the selection process to get the 30 trusts. How does she get involved?
She can certainly write directly to me and give me just a short briefing of what their hospital, what their trust is doing, what they're proud of, what they're looking to do. We know there's 7 regions in England through the NHS health programme, and at the moment we have 2 from every region, so that the aim is to have at least 4 from every region, and we want to ensure that we cover acute community and mental health. So all aspects, anyone that really feels that their trust is trying to do something different and would like to be part of that programme, then please write to me direct.
Okay. Question from Paul Fieldhouse of Aramco. How soon will you be able to include waste and surplus catering equipment in the hospital waste agenda? Is that something that's occurred?
That's good timing. Had some conversations last week, so we're linking closely with Fiona Daly, who's in the sustainability team, and there is recognition to know that we need to use our equipment in a much more fundamental way, and also have a way that in essence, if you don't need equipment, I'm sure there is someone else out there that does need it. So having that resale value of it as well within our own industry. So that is work going on. But again, happy for anyone to write to me direct to share their experience.
Right, thank you. Ian Drury now wants to know, why are we not concentrating on using more local companies for dairy, etc., and going back to cooking with fresh food on all of our sites?
Okay, so two parts of that. Well, we're working obviously with DEFRA around the national food standards and also government buying standards. We need to stay aligned to that national food strategy. We very much encourage the use of our local industries, and that's easier for some regions than others. But I've always felt there is a place for all, and I think every trust needs to look at the dynamics of their region and what they can do and how they purchase. What was the second question, David?
I mean, he's looking for two things here. Obviously, sourcing from local companies, but also cooking from scratch effectively with fresh food on all sites. Yeah.
Well, again, if when you think how much now each NHS establishment actually has either a cook freeze or a cook chill, or they're getting food directly from a CPU, it's a pretty high number. We're up around almost a 50-50 split now. It is not going to happen that we are going to have fresh kitchens in every hospital in the short term. It may be something in the long term that the government are really keen to invest in. For me right now, it is about improving the product and therefore working with our chefs as well as our suppliers. We mustn't take for granted the shiny gloss, the thinking just because we create fresh food, it's any better. We have, by traveling around the country, it is not always the case. And we've got to remember that food needs to be at its best at the point of service. And I've often seen fantastic food being cooked, but by the time it reaches the patient plate, it is not how it should look. So it is getting the balance right, and it is supporting each trust, each hospital in the way they produce their food and the way they serve it to the highest possible standard.
Okay. Now, we have mentioned technology earlier, but I'd be interested in your views on the role that technology and IT can play in the review, because obviously it's demanding quite a lot of people. We know that the money isn't necessarily always going to be there. So is there a role that technology can play in helping to sort of bridge that gap?
Yeah, it's enormous. There's no doubt. We're already seeing some trust do some great things. I mean, just as a couple of things, that you get effective ordering. You can order close to the point of service. It can link into the patient care plan. It can help you minimize waste. The way you manage our allergies and our diet planning, our staff training, and our menu design, all of those things bring everything together. And we talk very much about that power of three, and by linking food into the care plan through a system can help us understand that when a patient comes in, what position are they in, and how can we help their recovery and get them to a point where they go where they want to be, and that is home. But they can only go home once they've reached that nutrition and hydration that they require. So I believe that digital can help us do that quicker, effectively. And the great thing is we have that audit capacity then, so we can see how that patient has recovered quicker.
Okay, that's terrific. And now we're going to hear from two people who've got first-hand experience of just how that can work in practice. So I'd like to turn now to Abigail. Abigail, are you there?
Yes, thank you, David.
Right, if you could tell us a little bit about what you've been doing in Scotland, please.
Absolutely. I'm just going to share my screen. I've got some slides to talk through, if that's okay.
Yep.
Can you let me know that those are available now?
Yep, we're seeing them.
We're good. Okay, brilliant. Thanks very much. Okay, so good morning, everyone. Like I say, thank you for having me here today. A little bit about myself and my organisation to start off with. My name is Abigail Cork. I'm a programme manager. I work for National Services Scotland in a division called Health Facilities Scotland, and we're the support body for all NHS boards across Scotland. We deliver a wide range of support services. In Health Facilities Scotland, our focus is the provision of support and guidance across a range of healthcare facilities topics, but catering service is one of our key support areas. And today I'm going to talk about our national implementation of a catering information system across Scotland. And I'm going to talk through some of the benefits of doing that nationally, but also some of the challenges and where we're at now and what some of our key lessons have been. So, to start off with and give you a bit of context, this is how we got to where we are today, giving you a bit of a timeline. So back in 2016, there was a national review of all soft facility services in healthcare in Scotland, and that identified the provision of a modern integrated national catering information system as a key area for development for the country. So as a result of that recommendation, there was some activity to understand the costs and benefits of doing that, and that resulted in the development of a business case that went to the Scottish Government that sought funding to support the purchasing of a system for all boards in Scotland. And the business case sought the funding for the software for a system that would include all production management support for patient catering, so including stock management and control, purchasing, management of food waste, also electronic patient meal ordering, and also the support for retail, so that non-patient catering aspects. On all of that in the context with having the potential for system efficiencies through creating those digital links to other operational systems as well. So the business case really outlines some of those financial and health benefits that have already been mentioned today, actually, but this one focused really heavily on the potential for the management and reduction of food waste. So at that time, the cost of food waste in the NHS in Scotland was estimated at around £1.5 million per year, not including the cost of disposal. And the Scottish Government was really clear on a target for around 33% reduction of food waste by 2025 within their own economic strategy. So that business case also recognised that the system would enable boards to comply with recent changes in legislation related to food safety, disclosure of food allergens, as well as improving the patient satisfaction through that reduction of time between ordering and receiving their meals, and also a mechanism for providing efficient patient feedback within that bedside ordering tool. So we were successful with that funding request, and we set about fine-tuning the specification in collaboration with catering leads from across the country and with support from IT and procurement partners from within Health Facilities Scotland. And specifying that system was really quite a big task from a national perspective. Work had begun on this a long time before the funding was actually confirmed, and it was really written with the aims and outcomes of the system in mind, from using experience and the perspectives of those people working in catering and considering their existing systems and processes to ensure all of their needs were met. And as you'd expect, the specification really formed the backbone of all of the tendering process, and that took around 8 months from an advert to award. So in 2018, we had the award and the contracts were agreed, and we set about planning the implementation, and we did have quite a tight implementation window because of the Scottish Government funding window. So we had only 18 months to get all relevant boards to commit and to ensure that funding was safe. But why did we choose to go to an approach of a national system? So in NHS Scotland, a key part of our service strategy is to adopt a once for Scotland approach where possible. So to reduce the amount of variation of approach from board to board, to work together really collaboratively to develop systems and process that can apply everywhere, and to provide equitable support to very small boards who can then release their time and resources to focus on clinical service delivery. So a central system would be able to be centrally managed and would enable boards to demonstrate compliance in a really reliable, a really consistent way, and reduce local costs also by carrying that burden of system development and management nationally and centrally, and of course the elements of realising economies of scale within that approach. So in Health Facilities Scotland, we've got access to national IT support, national procurement, legal support, so we're well placed to facilitate that approach. So let's talk about some of the successes. So you saw that we started implementation in November 2018, and obviously putting aside the delays that have occurred obviously from the last year, we're still moving towards full implementation of the planned system, and we've got 14 out of 16 territorial boards have actually taken the funding and taken up the system to date. We're sitting at an estimated 70% of implementation achieved. So when completed, this will actually cover well over 90% of the healthcare estate in Scotland. It really means we've exceeded our target, our scope in the project in terms of coverage. So initially the scope was really focused in on larger sites and central production kitchens, but we've actually been able to offer funding to smaller sites as well, so they can benefit from that functionality. In terms of outcomes, it's quite early days for us in terms of measuring the outcomes of the implementation of the system, and we're in the stage of developing a measurement strategy to look at the impact, and that'll cover the basics such as waste costs and production costs, but also it will cover patient experience in terms of satisfaction with the service, staff satisfaction, and also it will cover measures of the usage of various functionality within the system. So what I would say is we're already getting feedback of reduced production costs from the sites that are now a little bit more mature with their usage of the system. So at a national meeting last week, one board was reporting that they've now completed implementing and fully bedding in the system, including that bedside ordering element in half of their board. And they're now really seeing a really clear financial difference between the two halves of their board. With the Eastern Estate using the full system, having a reduced cost of meal production of 10 pence per meal in comparison with the west side of the board, where they've only implemented so far the back office function. So this is in a board that's producing well over 11,000 meals per day across the board area. So you can imagine they're really pushing quite hard now to roll out the bedside ordering across the full estate to release some of those benefits. So we've talked about the successes, now onto the challenges. As you can imagine, with a national rollout, there have been plenty. I've broken these down into 3 areas of change management: financial and technical. So starting with change management, with the provision of the funding being sought and arranged nationally, there was perhaps a bit of a less of a clear incentive at the board level that they needed to appropriately assign management and leadership resources at the board or site level. And whilst it was clearly outlined in the project plan where resources and personnel would need to be allocated within a designated project team approach, it didn't always happen. And actually, for those that didn't have that resource, it really seriously hampered their progress. And that also really affected not just the coordination of support, but the general pace and the kind of general motivation to proceed. And a lot of boards really underestimated the level of engagement or input required from their own catering team in building and populating the system. A lot of cases, the source data also that they wanted to use to really create menus and recipes and production plans and so on was somewhat out of date, or maybe a bit sketchy in terms of quality. And really a good amount of attention was needed to really rectify the quality of that data before building the new system. I want to touch also on that uptake of the bedside ordering system. So I talked about that experience in terms of the impact on production costs. But there are challenges in delivering that bedside ordering system, and many boards have been a bit more resistant to implementing that tool. In some cases, it's because they simply don't have access to influence the available resources to do that verbal collection of meal choices from patients, in comparison with that more traditional method of paper-based and collation of patient menus from facility staff. So, but what we know is that the optimum approach is that nursing staff engage in supporting patients to make their meal choices, and where this is happening, the feedback is really positive. But in many sites, this is really seen as a bit of an impossible change, because nursing staff, it's felt, are just going to be too busy to engage in that activity. Yeah, and we're really finding that where that is in place, it's really positive, returning positive impact on patients in having that really engaged conversation about options at meal times. So yeah, the boards who have implemented their production management, their kind of back office function, if you like, and their retail, they won't accomplish all of the benefits that were outlined in the business case unless that electronic meal ordering system is also applied. So on this point, and it might sound a little bit negative, but in some cases the rollout has suffered from perhaps a little bit of a lack of ambition. Some boards have seen the new system as a sort of simple modernisation of their existing or their legacy systems, a like-for-like replacement. And they didn't really see all the opportunities that would come from that were available for use in the new system that would really enhance their services and management much more effectively. This is actually gradually changing as the boards that went first, if you like, are really starting to articulate the positive impact that they're experiencing within their services. I'm going to touch on the financial challenges. 100% of the funding for the software came from the Scottish Government, but the implementation of the system carries hardware costs that aren't covered, and that includes the purchasing of IT equipment and also the hosting costs of supporting the system either in-house or through a third party. Now, boards obviously had to carry out their own internal business case process to access that funding. The case for change was pretty clear, but the processes are very variable across the boards, and some were quite painful and long-winded. So that did create a fairly significant barrier for boards. And there was a big issue that emerged at the beginning of the project, was that there was a huge variation in terms of the cost of hosting services in-house from board to board. We addressed it pretty quickly through the procurement of a dedicated NHS Scotland server. But it did mean that some boards had to go through another round of approvals to allow for that third-party hosting. And moving on to the technical issues, as you can imagine, there's a fairly wide range of technical barriers to jump when carrying out any IT projects. In this case, there were probably two key aspects: accessing the available IT support on site to support implementation, and also gaining the approval from local information governance teams to proceed. Information governance appears at first glance to be a matter of national policy, but actually there's quite a large amount of variation from board to board in terms of local preferences, local requirements. So effectively we had to go through information governance approval 14 times to gain approval to proceed. So that takes us on now to where we're at now. As you can imagine, over the last few years, we're now moving into a bit of a snagging phase in terms of the planned implementation, and we're finishing off the work to link the system to other systems, namely the national purchasing system, which will create this seamless commodity procurement across the systems. And we're moving into a project review now. This is just starting. We're looking to complete the review by about September. And that will obviously reflect on the process so far and deliver some recommendations for future use of the tool. And by that time, we'll have also developed that measurement strategy I referenced to monitor usage and to measure the uptake of new functionality, and also to measure those outcomes that we talked about, waste and cost reduction, etc. In terms of lessons learned, as you would imagine, we haven't started the review yet, so some of these are fairly obvious what we've learned. In planning a national rollout, we really based a lot of our planning assumptions on what we learned from a few pilot sites, and this had a lot of benefits, but we really understand that you can't compare or apply the implementation process that worked in our kind of keen, engaged early adopter board to processes literally everywhere else. And crucial for us would be in addressing those IT and information governance challenges really early in the programme, rather than kind of having to knock them down as they arose. Allocation of in-house support is crucial, and having that available to drive it and manage the process locally is really crucial to success. And we really need to have a bit of a reflection on the funding process. Was providing funding purely for software the way to go? And we need to do that in collaboration with the boards and get some feedback from the boards on their feelings on that. And the last point I'd like to make is just really thinking about the way we delivered the specification. It's always really challenging to create a specification to meet everybody's customer needs and service requirements, but we did base it on what we had already. So we looked at our existing services, and I think we really created the very highly specified, really nailed down functional specification, rather than allowing a more of an outcomes focused method. That allows the supplier, the technical expert, to really deliver additional benefits to the customer and to really help us as customers to understand the art of the possible with a system like this. And that brings me to the end. I'll wrap it up there. I think there might be some opportunities for questions in a bit, but there's my contact details if anybody wants to contact me direct to know more.
That's great. Thank you very much, Abigail. And we'll turn now to Gareth, who's I hope going to be able to tell us a little bit about what he's been doing in Wales on along the same lines.
Yeah, no, absolutely. And good morning again. And as I said previously, I'm Gareth Hughes. I'm the Divisional Director for Estates and Facilities in our Devon Health Board in South Wales. So in terms of context, I work for a health board that has a 1.2 billion budget, about 14,000 staff. And because we're in Wales, it's integrated health, so it covers community, acute, primary and mental health. So it's a real good mix of services we provide. In terms of the hospitals, we have 10 hospitals. One's just been opened back in November, which is a critical care hospital. We have 3 ELGHs and then a number of other community and mental health hospital sites. In terms of my remit, I have around about 80 million budget for estates and facilities across the patch, just shy of 1,500 staff. So it's a really great remit in terms of what we actually do. I think the key theme as I go through this is around putting the patient first, because patient dining or catering is one of the key elements that helps patients recover and then leave hospital. So it's fundamental. But in terms of our journey, in terms of the health board, I set up a continuous improvement team probably about 3 years ago, which had a very clear focus on consistency, quality, patient experience and cost. And the way that works, I seconded staff from frontline staff up to middle managers to start looking at what we do and how we can make improvements across the division and support the organisation as a whole. So we looked at benchmarking variance in terms of how we perform internally, because we have 10 different hospitals, and the hospitals, if you go back years, were different trusts and different health boards, so there's different ways of working continually. But we had a real focus on understanding where we could actually make a real fundamental difference. And then that played a significant part, which is also a theme about talking and engaging with stakeholders. So one of the key elements that came out was that there was more we could do around patient dining and that experience. So the team themselves started looking at how we were actually delivering our patient dining experience. So we deliver over 2 million meals per year across our different sites. It's a combination of fresh, scratch, through to frozen, through to bulk, through to plate. So it's a real mix of what we do and how we move it forward. But what became really apparent is that we had no standardization across the health board. There was a process where patients would order the day before. So if you were discharged, and I took your bed today, I'll be eating what you ordered yesterday. And there's that lack of individual support for patients as they came through. As a consequence of that, we had significant both protein waste and plate waste. So we're probably running about 9% in terms of the kind of protein waste. And we were probably running with plate waste up to about 18%. So it was significant. And it tied to that waste is obviously a significant cost. We also had nursing staff who were actually doing the menus. And again, it was a little bit ad hoc at times, and we wanted to understand how we could support that process. And again, because we're a big organisation, we had different processes. So generally, we used paper-based that didn't really hit what we needed. So what we decided to do was look at how we could make a change, integrate technology, and make a real difference. And the basis went forward the fact that it fitted quite nicely with work that has been done across Wales in terms of a kind of national direction and reducing food waste and improving the quality of food. So it linked with our hospital catering patient nutrition review, and also within Wales we have a process where it's about prudent healthcare. So you invest appropriately. So we put together a number of working groups. We looked at benchmarking. We actually went up to Scotland to see what they're doing in Scotland. That was fabulous. You really have to see the change to bring it back, and that was really helpful. And again, we started working with our stakeholders. So it wasn't just a senior viewpoint about how to take it forward. It was engaging from the staff to the patients, to the frontline staff, to our chefs, to our caterers. Everybody had an input in what to do. So based on that, we developed a business case at the same time as a kind of procurement process. We linked everything back to the patient experience and patient quality, but also a real focus on putting the money in the right place. And if there was the opportunity to save money, as we believe there was at the time, in terms of our high wastage, we could reinvest that process. So we went through an all Wales procurement process. It wasn't, the process was funded, but the funding for the actual implementation was left down to the individual health boards to decide if they want to take it forward. And we certainly did. But the key thing in terms of both the business case and the procurement process is it's got to be robust, and you've got to be able to measure the benefits, and you've got to make sure that you set the line at the very start, which is appropriate. And I think the key thing that I found very beneficial is that what you need is whoever you end up aligning with to support you with the IT process, they've got to be a partner, not just a provider of services or a provider of IT. They've got to work with you and they've got to grow with you as you kind of develop. So back in 2019, the business case was supported, the procurement was in place. We draw down the contract and we start the process. And again, we had a very clear focus that we need to measure what we're doing, because we took the view that we'd actually fund it internally. So, and I think another key point here is that if you do it right and you roll the process out appropriately, it is self-funding. We actually pay back our investment within 12 months, as well as enhancing that whole patient experience. But in terms of project management and governance, we had a very robust approach to program management in terms of our plan. We have complete stakeholder involvement from IT through to finance, HR, to staff side. But most importantly, also the company that's delivering, we're integrated into that team. That made a massive difference. And we were very clear we had go no-go points. So up to a 4-month period, we roll this out across the whole health board. The key is that you make sure you have the resource in place. So you can't get staff doing this as part of their job. They've got to do it full time. They've got to make it work. The benefits are massive. Comms in terms of to the patients and across the organisation are fundamentally key, because that makes all the difference. And on the back of that, you've got to make sure that staff really understand the reasons for what we're doing and actually get trained appropriately soon. So having that process, we did appropriately hold to account and manage the rollout, and it went exceptionally well, I have to say. In terms of the benefits that we've seen over the last 18, 24 months, we now have a very clear patient focus in terms of patient dining. So they order on the day, which is key. The hostesses within my division actually sit down with the patient and they have that interaction, and that is empowering for our hostesses because they get to know the patient and they have that time to talk. The information is live and we can utilise it more appropriately. It has reduced down our waste to less than 3%. So as I say, if you do it right, resource right, and manage it in the right way, it pays for itself. We've released nursing time because nurses don't do the menus anymore, so there's more time for them to care. It's like I say, it's real-time information that makes a massive difference, and it just demonstrates how well technology can work if you play the whole process through. When we went through the tendering process, as well as the catering element, I was very keen here to ensure that part of the procurement process we could pull down the extra modules, and that kind of fits into the kind of opportunities going forward. So technology drives information, and information drives decisions. And if you get the decisions right, you can enhance quality, you can enhance patient care, you can enhance that whole putting the patient in the centre. But you can also take money out in a way, and then appropriately put it in a different place that can then help develop another service or make a change elsewhere. So our next step is to really align it with our ordering process, so that the real benefit is in the fact when we produce, it reorders. So that's our next step. But I guess in summary for me, thinking about last night when I was kind of putting this down, is that there's kind of 4 or 5 key things that I found that work really well. Is that you need a real robust business case, procurement process, and governance process to make sure you actually deliver it. But with a patient focus in the centre, you've got to resource it appropriately because it pays for itself. If you cut corners there, you won't get the benefits out. Stakeholder involvement, it is a journey. So, but the stakeholders aren't just the clinicians or the nursing staff. It's really talking to the patients and talking to the staff who make a difference. The other key element is you need to align yourself to a company that is your partner in this journey, not just who provides it. And comms and training, you've got to fundamentally support the staff who deliver it because it makes a massive difference. And like I say, we've introduced we've got catering, bedside ordering, we have the cleaning, we have the portering, and another module in place. And they've all been cost neutral, payback within the first anything between 7 and 18 months. And it all drives a new way of working, it all drives best practice, and it all drives the patient at the centre. So hopefully technology works, and that's my kind of summary of how well, if you facilitate the process, you can get significant benefits for the organisation and patients. Thank you.
Okay, Gareth, thank you very much for that. A bit of a word of warning to everyone. We're probably going to be running over by a few minutes today, but there are a few things yet that I still want to talk about. First of all, I wanted to bring in Mark now on that point. First of all, for his reaction to what he's heard about those two presentations, and maybe some thoughts of his own on the opportunities that IT and technology provide for hospital catering. Mark?
Thanks, David. Yeah, great to hear from Abigail and Gareth, and obviously having been the contract award for both boards, Synbiotix have supported the national rollout in Scotland, and we've done quite a lot of work, not just with Gareth's health board, but a number of other health boards in Wales, and it's been an amazing journey. I joined the company about 2 years ago to deliver on the National Catering Information System in Scotland and to roll out Wales, and obviously we look after lots of other trusts up and down the country, and it's been a bit of a roller coaster ride, I would say, over the last 24 months, but we've picked up a lot of useful learnings along the way about how to do this on a national level. Certainly the Gareth's points around project management is absolutely key. That sometimes I think when this gets awarded, people feel like it's something that's going to happen to them rather than something that they need to do. So one of the key learnings is that it definitely needs to be thought through properly from the start as to what resources are required internally, both from IT and boots on the ground in catering, to deliver on a catering information system that's going to deliver the benefits that Gareth clearly articulated there. And again, in Scotland, where because it was centrally funded, again, sometimes maybe the idea was that it was going to be something that happened to them, and the boards that excelled at it and took it further forward quicker were the ones that had really good project management resources and the ability to deliver on that vision from the outset. In terms of setting up these systems and understanding how to do that in the most efficient way, I come from a nutrition background and have been around NHS catering for a long time, and one of the things that I've always had a bit of a bee in my bonnet around is the use of allergen folders with ticks and crosses that are up on wards and going dusty. And for me, digital solutions to those problems are absolutely key. Systems talking to systems is a far better way to access that data than having a poor dietitian stuck in a room trying to pull information from various sources. So one of the things that I'm really keen to advocate as part of the national conversation here with regards to digital systems is the setting up of a national database that, say you want to work with the NHS as a supplier or a manufacturer, then there should be a national place where everybody puts their data. It's something that worked really, really well in Scotland, and it's in an agreed format. So if anybody wants to try and build one of these systems, be that Synbiotix or even one of our competitor companies, this isn't about just doing things that are great for us, but if there was one place where we could all go to pull that data in the same format, it would make setting up of these systems so much easier, and also totally improve patient safety, because we all know that with the best will in the world, manually translating data from allergen sheets or PDFs that we still get presented with into some sort of format that can be used for patient bedside ordering can be prone to error. But if I've got systems talking to systems, I know that database is going to be absolutely maintained by the supplier. We just put in an API call and it picks up that information seamlessly. I think they're the two pieces that I would really like to stress as feedback from Abigail and Gareth's presentations, that yeah, project management is absolutely key, and the ability to have some sort of national database where we can all pull data from would be really, really useful, not just for us at Synbiotix, but for everybody who was trying to do this.
Okay, that's great. Perhaps because we are pushing time now, we're going to try and wrap up a little bit, but I do want to just turn to Phil now. Phil, on that point about a national database, how, from your perspective, is it a good idea, and is it something practical and achievable?
It's certainly a great idea. I think we've got to move from meeting our service demands to go to a point where there is a collected effort to actually enhance our services. And sometimes we aim for what is the standard. Actually, we should be trying to rise above those standards. And I think the only way of doing that is learning from each other. And what Health Facilities Scotland have done a terrific job by pulling that information together. And just to help us realize what it does, we are moving to an area now where, we had the protected meal times, and there still is a place for a fixed menu in a protected space. but we also want things like flexible menus. We have to be aware of the cultures and religions. You know, labor menu ordering is labor intensive, isn't it? So if we can use our digital systems, which is what we're doing in the clinical circle, if we can use that to enhance our food ordering, we need to do it now.
Okay, that's terrific. Well, there's lots more that we could have talked about. Unfortunately, we're running short of time now. So I'm afraid I'm going to have to wrap it up and say thank you again to Phil, to Abigail, to Gareth and Mark, and to you for joining us today. There will be a full link to the recording of this webinar available next week on the Public Sector Catering website. Any questions that we've been unable to address today, we'll be putting to the panel and hope to have some answers for you that we will post on the website alongside the recording. We have coming up now the name of today's webinar sponsor, Synbiotix, and our thanks again go to them for enabling us to put on today's event. On other slides coming up, you will see that our next webinar will be on May 19th, when we'll be joined by Dr. Rupi Aujla, the man behind the Doctor's Kitchen website and books, who will be talking about his work and plant-based diets as part of our plant-based week of events starting on May 17th. And I'm also pleased to say that we'll be talking to Dave Oliver, Head of Prison Catering, on June the 10th on a webinar then as well. That's it for us today. Goodbye.
Thank you.